So we have several types of pain. Acute pain is directly associated with something immediately that caused it. So something like a burn. If you bump your toe, that is acute pain. So how does this affect our clients? Well, uncontrolled acute pain can cause a cascade of hormones to affect its organ systems. It can cause stress responses, which would cause their heart rate to go up, increase respiratory rate, and increase their blood pressure. So a lot of times if you're taking the blood pressure of someone who's in severe pain, their blood pressure will probably be elevated because of that. So what we would like to do is give them some type of analgesia. We can give medicinal as well as non-pharmacological management. We have opioids available. And of course, the most important thing is just to communicate with them. Now, chronic pain is pain that's going to persist for 3 months or longer. So this is just something like arthritis, back pain. This leads to some maladaptive changes. So eventually their body kind of adjusts to it. However, if we don't manage that pain, it can perform just their ability to do daily tasks. It can affect all aspects of their life, help interrupt with their sleep, and could cause them to go into a depression. Now, if you have someone in chronic pain, we talked about how acute pain is going to increase some of their vital signs. You're not going to see that increase with chronic pain because their body has adjusted to that. And then there's a couple of other types of pain that I want to look at. Neuropathic pain, and the physiology here is it's caused by disease or damage to the nerves. Neuro meaning nerve, paths that transmit sensory information from the body to the brain, and that causes pain. If you have neuropathic pain, you're usually going to report constant or intermittent episodes where you feel like your extremity or whatever is hurting is on fire. It feels like it's burning, it's prickling, it feels like pins and needles. Some people say shooting or freezing in that area. Some people say it feels like when you're laying on your arm and it goes to sleep. So they have a bit of a higher level of pain, so therefore they have a lower quality of life. They don't feel like getting out and doing things. So the same things we see with a chronic pain person, we're going to see in people with neuropathic pain. And then nociceptive pain. This is the last one I'm going to talk about. The pathophysiology for it is from some stimuli such as temperature, pressure, inflammation, trauma, and chemical agents. So it's initiated by nociceptors throughout our skin, muscles, organs, bones, and joint. So this can involve the inflammatory or chronic pain that we see, and especially whenever we see this for a prolonged period of time, it's going to affect their lifestyle. So we have some medications, opioid agonists and opioid agonist antagonists. So most commonly we know about the opioid agonists. These are going to be our things like morphine, fentanyl, pyridine, hydromorphone, and methadone. These are for use of moderate to severe pain. These are going to make you sleepy. They help to lessen some anxiety in some people. When we're giving these opioids, our number one assessment should be checking our client's breathing. Okay, we're going to check that breathing because this can sedate the respiratory system as well. Now, another one we don't hear a lot about is going to be butorphanol. This is what we call Stadol, is the trade name for it. And that is kind of something we use as an adjunct to anesthesia. So opioid agonists, remember I'm talking about the morphine, the Demerol, those types of things. They bind with the mu receptors at the opioid receptor site. So that prevents them from sending that pain signal. So it prevents that or closes down that pain signaling pathway. So what's it going to do to the body? As I mentioned earlier, it can decrease our respiratory drive. Long-term use can cause adrenal insufficiency. They might get hypotensive. They might have some syncope or dizziness. So we want them to use this. Now, morphine is indicated for a wide variety of painful conditions when for some reason the pain has not responded to other analgesic agents. We also see it given a lot post-surgery. So contraindications for opioid agonists. If they're taking any other CNS depressants, if they have a bowel obstruction, if they're hypersensitive to it, if we think they have a head injury, increased intracranial pressure, or if they have impaired consciousness. Now, if you already have a respiratory disease and you're having trouble breathing anyways, we're going to advise you to use this with caution. Another group of people that we want to use with caution is going to be those with a history of an opioid disorder or opioid use disorder. So, for example, someone who may have been addicted to opioids at one time. Some of the side effects, again, sedation is the big thing. It can cause nausea and vomiting. Some people, especially with morphine, get like an itching on their face, especially. One of the huge side effects that we see all the time is constipation. It is going to slow everything down, so it is going to slow down their GI system as well. So anytime we have someone on long-term opioids, we probably want to go ahead and give them a stool softener as well. Some other effects, I mentioned hypotension, bradycardia, syncope. They also get euphoria sometimes, and some people enjoy that euphoria, so that increases the risk of misuse. So when we're educating our clients, we want to make sure we go over the purpose of the medication. We want to talk about how to take it, any side effects or adverse effects, how often to take it. Again, find out if they're taking any other CNS depressants. Make sure that we're telling them to drink plenty of fluids to prevent them from getting constipated. And remind them too that opioids do have a high risk for dependency. So we want to use them for a short period of time. The next medication we're going to talk about is a dual mechanism analgesic. It is tramadol. The trade name is Ultram. So it's going to bind with those low affinity mu receptors. So that is going to inhibit the ascending pain perception. It also inhibits the descending pain pathway, so those cannot merge together. It also prevents the reuptake of norepinephrine and serotonin. Norepinephrine and serotonin is going to make you feel better, so if it's preventing them from leaving the body, it does give you a little bit of feeling a little bit better. Whether you actually feel euphoria or not, it does increase the risk or decrease the risk of depression. So it is for pain, and it also has anxiolytic, meaning anti-anxieties and antidepressant effects. We do still have to watch for respiratory depression, sedation, and hypotension. So if we have someone with moderate to moderately severe pain, if it's acute or if it's chronic, they're going to be a good candidate for this medication. We don't want to use it in those that are younger than 12 years of age. We want to make sure that they don't have any liver damage already, make sure that they've not had problems with respiratory depression or a GI obstruction. And as I mentioned earlier, sedation, dizziness, headache, nausea, and constipation can occur with this. Now for adverse effects, they might have seizures. It can cause some urinary retention. If they take it with too high of an antidepressant, they could have serotonin syndrome. So we want to teach them the purpose of this medication, how they are to administer it, remind them of the side effects and adverse events that could happen here. And we want to let them know to increase their fluid intake because constipation may occur. We want to teach the caregivers to monitor that client's respiratory rate. We really don't want to be taking it for a long time and then just stop taking it all of a sudden, because they can go into some rebound pain with that. Opioid antagonist. Now we should be pretty familiar with this one. This is naloxone, or the trade name is Narcan. So what it does is it competes with those opioids to get on that opioid receptor. And what it does is it goes and it knocks the opioid off of the receptor and it sits there. Okay, so remember that part of it, because those opioids can come right back and get on that receptor. So we always teach people, if you give someone naloxone, you want to make sure that you stay with them. You may need to give them 2 or 3 doses. And we need to make sure that they get to the ER, because again, they could wake up, that opioid could come and knock the naloxone off of the opioid receptor, and they could go back to their unconsciousness, decreased breathing. All right, so the effect it's going to have on the body, it reverses the opioid intoxication, and it's going to reverse some of the manifestations of that opioid. It can also help with opioid-induced constipation. Again, it's a very, very short-acting drug, and it is for prevention of opioid dependence. We also want to remember that even if we don't know what this person has taken and we know they had taken something, it's still safe to give them. So for example, if I don't know if they overdosed on alprazolam or if they took oxycodone, I'm still going to give them the naloxone, because there's a chance that it was that opioid. If I give it to them and it's the anxiolytic, no harm, no foul. There's really not any contraindications that we would talk about for giving a naloxone. It can cause them to have some withdrawal symptoms that they don't like. The side effects are usually due to that acute withdrawal, so they might have nausea, vomiting, diarrhea, anxiety, and aggression towards you. And the most significant adverse effect that we're going to see with it is ventricular arrhythmias. Again, we want to talk to them about the purpose of the medication, how to administer it. We can give it intranasally, we can give it sub-Q, IM, IV, I believe as well. Next, we're going to talk about the non-opioid analgesics, and the first one we're going to look at is acetaminophen. Acetaminophen, commonly called Tylenol. We don't know exactly how it works, but we think it works with the COX mechanism of our central nervous system. It's going to disrupt the prostaglandin production and stimulate serotonin. So remember, I told you serotonin makes you feel a little bit better. So by doing that and interrupting the prostaglandin, it's going to reduce your pain and fever. So effects on the body, it's going to reduce your pain and fever. Some people can have hypersensitivity reactions, nephrotoxicity, metabolic and electrolyte disturbances, and it could, with long-term use, cause liver damage. So that's the number one thing I think that we worry about with acetaminophen is the liver. If they take an overdose of acetaminophen, we're monitoring that liver function very closely. It's used to treat mild and moderate pain and can also be used to reduce fever. So if we have someone who has alcohol use disorder or severe liver disease, we do not want to give them this medication. If you have alcohol use disorder, chances are you probably already have some damage to your liver. Side effects, GI upset, they might have some itching. Adverse effects would be, of course, the liver damage with long-term and high doses could cause some problems with the kidneys. There is something called Stevens-Johnson syndrome that can occur as well when you take Tylenol or acetaminophen. So we want to talk to them about the medication, how to administer it, let them know the side effects and the adverse effects. Tell them that it comes in many forms, that it is in many, many products. So, for example, if you take like Sudafed Sinus, something like that, or it has acetaminophen in it. So we want to make sure that they know that sometimes acetaminophen is added as an ingredient to other products they may be taking over the counter. And of course, we don't want them taking any alcohol while they are taking acetaminophen. The next category is going to be NSAIDs, and this is going to include aspirin and ibuprofen. NSAIDs are going to block the COX enzymes, okay? It's going to reduce our inflammation. It is going to reduce our fever and reduce our pain. So the NSAID suppresses our immunity, inflammatory conditions. It helps like with things like gout, mild to moderate pain. Think about like arthritis, tendonitis, you pull a muscle. Another one that's a COX-2 selective is the celecoxib, which we've talked about before, and that again is used for mild pain, inflammation, and fever. There is one of the medications that's an NSAID is called ketorolac. This is not good for someone who has active peptic ulcer disease or someone who's scheduled to have surgery or has a bleed already. With both of these, we want to make sure that if we have someone in or that's getting ready to go to surgery, that they stop these about a week before surgery because bleeding can affect. They can have some edema, hyperkalemia, itching, GI upset. That's probably the most frequent thing that you're going to see is GI upset. And again, if we take too much of it, it can cause a lot of disturbances in your stomach. It can erode away at your stomach. Some of the adverse effects, where we said liver for acetaminophen, we're worried about the kidneys here. The kidneys can be affected with large doses of NSAIDs, large and long-term doses of them. So it could cause anaphylaxis for somebody. It could cause shortness of breath. Again, Stevens-Johnson syndrome as well. And then the last one we're going to look at right now is just a local anesthetic, and it's lidocaine. Lidocaine blocks the ion transport across those neuron membranes, so that's going to prevent the transmission of the nerve impulses. It's going to produce a loss of sensation in a specific or targeted areas of the body to provide pain relief. So you might think about if we're having a procedure maybe that's painful and they'll say, oh, I'm going to give you a local. That's what they're giving is lidocaine. There's lidocaine patches. If you were getting stitches, they would probably inject some lidocaine before they started working on you. And your dentist now uses Novocaine, which is also a local anesthetic. Contraindications, we don't want to put it directly in broken skin. We want to watch and make sure it's not prepared with epinephrine. We don't want to do that because that could cause some cardiovascular events. Some of the side effects, you'll see redness, irritation, itching, rash. Those things can occur. And adverse effects, again, if we have high levels of lidocaine in our bloodstream, it can cause some systemic toxicity. The next medication we can use to treat pain is adjuvant analgesics. We have a couple of different ones we're going to look at. Antidepressants. A lot of antidepressants tend to have some anesthetic or analgesic properties to them as well. The one we're going to look at is duloxetine. It's going to slow the reuptake of serotonin and norepinephrine in our central nervous system. Again, if we can stop or slow down the reuptake, we're going to have more serotonin and more norepinephrine, and that's going to make us feel better. On the body, it relieves neuropathic pain, fibromyalgia, chronic pain. We do see it given sometimes for peripheral nerve pain from chemotherapy. I just kind of went over what we see it in when we're giving it. Fibromyalgia, musculoskeletal pain, neuropathic pain. We don't want to give it to someone who has taken an MAOI. That is a first-generation antidepressant. We'll talk about those at another time. We don't want them to take it if they have liver failure or angle closure glaucoma. One of the big side effects we're going to see are increased perspiration, decreased appetite, constipation, painful urination, drowsiness, fatigue, and insomnia. Now, I mentioned decreased appetite. Some people have an increased appetite, so some people will gain weight on antidepressants. Adverse effects, we want to watch for suicidal ideation. We want to watch for serotonin syndrome, neuroleptic malignant syndrome. They could have seizures, pancreatitis, and again, Stevens-Johnson syndrome. So we want to tell them about the medication. We want to make sure that they understand the side effects, the adverse effects, how to take it. Tell them, most importantly, if they begin to have any type of new or unexpected behaviors, thoughts of harming themselves, we do not want them to take it anymore. However, we do not want them to take it abruptly either, or stop taking it abruptly. This is a medication they need to be tapered down on. The next one is the anticonvulsants. Gabapentin is most commonly used. Gabapentin is used for a variety of things. It's an antipsychotic. So they think it binds to the calcium channels that inhibits entry of calcium channels to the brain, and it's going to send out neurotransmitters, okay, the release of neurotransmitters. It just helps to relieve nerve pain. We know that it does that. So indications for use: if I have neuralgia caused by maybe herpes zoster, like the shingles, if I have neuropathic pain, again, that neuropathy, diabetic neuropathy, and also people with fibromyalgia have had some good use with it. I don't want anyone to take it that's allergic to this type of medication if they have a history of substance use disorder or if they're currently pregnant. So for the side effects, remember this is going to affect several different systems. It can impair your coordination, it can make you weak, dizzy, vertigo, drowsy, weakness. It can cause weight gain. It can also make you really sleepy. So we want to let them know that this could cause you to become tired. So don't take it and operate equipment. Adverse effects or hypersensitivity reactions, again with the suicidal ideation, Stevens-Johnson syndrome, and rhabdomyolysis. Again with education, what are they taking this medicine for? How are they going to take it? What are the side effects? What are the adverse effects? And when they should call, okay? So again, this is a medication we really don't want people stopping abruptly, and let their provider know before they start any new medication, and let them know about all over-the-counter medications, because sometimes those can cause a significant reaction. Cannabis is a complementary and alternative medication. We don't really know what the mechanism of action. They're doing a lot of research on it, but we do know there are two cannabinoid receptors, CB1 and CB2. CB1 receptors in the brain help to regulate our neurotransmitters, norepinephrine, serotonin, dopamine, and GABA. So if you think about, they feel a lot better whenever they take cannabis. CB2 receptors, these are in our peripheral tissues, and they play a role in the immune system, and it reduces inflammatory responses. We can use it to reduce chronic pain, neuropathic pain. Some people with spasms, like have multiple sclerosis and have spasms, that can help them. We use it to treat with nausea associated with cancer or chemotherapy treatment. We've seen it used in people with seizures. We see it used for people with anxiety. We can use it for pain management when there are no other conventional treatments that have worked, or if the conventional treatments have severe side effects that are not desirable. Contraindications, if we know we're allergic to it: cardiovascular disease, heart failure, and we don't know if there's any safety. We haven't established that for pregnancy and breastfeeding. Most common side effects they're going to have are dry mouth, nausea, dizziness. They might have some disorientation and euphoria, confusion, sedation, tachycardia, and sometimes they can have difficulty breathing. For adverse effects, it can cause them to go into an acute psychosis that is usually reversible. They can have a panic attack, and they can have hyperemesis syndromes that can actually do the opposite sometimes of what we want it to do. Teach them why they're taking it, and let them know about the side effects, adverse effects, how to take it. We want them to start with a lower dose and work up until they get their relief that they need. We also want to tell them if you're purchasing this, we want you to purchase it from a reputable retail outlet and ask for the quality and purity lab test results. All right, so we have several different types of headaches. The first one we're going to talk about are tension headaches. Tension headaches is the primary headache that a lot of people has. It has a multifactorial origin. It includes peripheral mechanisms, central sensitization, neurotransmitter imbalances, and psychological factors. The combination of our muscle tenderness is due to the peripheral activation of nociceptors. Again, that causes all that tenderness and tightness they feel around the skull. As it is the most common type of headache, some people will say it's gradual aching and pressure. They might feel it on both sides of the head. This type of pain will not worsen with activity. So some of the triggers that we might see for things like stress, lack of sleep. If you're not eating, if you haven't eaten in a while, you can have a tension headache. And it does lead to a lot of sleep disturbances, and it accounts for high numbers of missed work days. The next type that we have is the migraine headache, and that is a complex neurological disorder, and it occurs because of multiple vascular, neurological, inflammatory, and hormonal factors. They are described as moderate to severe throbbing and pulsating pain. Usually it's on one side of the head only, it's unilateral. They might have some dizziness with it, nausea. They might not be able to see any light. They might be very sensitive to any kind of stimuli. Triggers include disturbances in their sleep. Again, if they're not eating correctly, change in weather can cause it, stress, changes in their environment, and menstruation. If they have chronic migraines, which by chronic we mean more than 15 per month, they have a hard time maintaining employment, and they have a lot of difficulties with their family and friends because they cannot attend all the activities because of their headaches that they're having. Cluster headaches. This is an extreme pain in a cyclic pattern of occurrence, so they'll happen in 2, 3, 4, usually at the same time of the day over a period of weeks to months. They're often associated with autonomic manifestations. The pathology is very similar to a migraine headache. The distinctive feature here is the parasympathetic activation of neurons in the trigeminal vascular system. So that causes projections to travel to the facial nerve and ganglionic sympathetic nerves that innervate the glands in our eyes, nose, and pharynx. Cluster headaches are also debilitating headaches. They have a very high pain level that some people say it rivals giving birth or experiencing a shotgun wound or passing a kidney stone. They'll usually have sleep disturbances. They report feelings of depression, anxiety, and suicidal ideation. And a lot of times, when they're experiencing their attacks, they're usually unable to work. And then the last one that we have is sinus headaches. And the pathophysiology here is it's secondary headaches that occur when there's some kind of underlying infection, inflammation, and congestion in the sinus cavities. They're usually mild to moderate in intensity. So people who have these headaches will experience headaches plus the manifestation of that infection or inflammation. So they might have a lot of mucus or colored nasal discharge, report facial pain and pressure. They might have nasal congestion, stuffiness, or blockages. And they describe that pain as pulsing or throbbing pain. Sometimes they'll say it's worse in the mornings, and if they lean their body forward, they'll feel all that pressure. So how are we going to manage these headaches? So tension headaches, we like to use NSAIDs like Analgesics We also like to use tricyclic antidepressants, which are second generation antidepressants, and we'll talk about those later. They may take these for mild episodic headaches. If they have chronic tension headaches, we will give them something to try to prevent the headaches. And so we will use a tricyclic like amitriptyline for that. Migraine headaches, we want to give them medication to stop the acute manifestation. So we want to give them serotonin agonists, which are like the triptan. So sumatriptan would be one of these. Preventive medications may vary depending on their circumstances, how often they're having them. If for something we don't know, if we don't know what's triggering it, we could give them some type of anticonvulsant or beta blocker, again, a tricyclic antidepressant, an SSRI or antidepressant, SNRI, angiotensin receptors. There's several different things that we can give them. Cluster migraine headaches, divalproex and topiramate. These are anticonvulsants, and they've been found to be effective in the prevention of migraine and cluster headaches. We don't know how the anticonvulsant prevents it, but we know that it helps to stabilize some of those neuronal membranes in that. And again, if you have frequent or chronic migraines, this might be your first line for preventative medications. Cluster headaches, these are treated with maybe an inhaled triptan, such as sumatriptan again, and we can also give them some oxygen as well. That tends to help. For the sinus headaches, if it's an infection, we want to make sure we get them on an antibiotic like amoxicillin to treat that infection. They need some decongestants, and that can be used to relieve some of that congestion and pressure, and hopefully that will decrease the inflammation and they won't have the headache anymore. Acetaminophen for pain relief, NSAIDs for pain relief, and also to decrease the inflammation. One of the common decongestants that we use is pseudoephedrine. This is it decongest, constrict blood vessels in the nasal passage, so that's going to relieve some of that nasal congestion, which again, all that congestion and pressure is what causes the headaches. Not much to talk about with general anesthesia. We have our sedative hypnotics, propofol, etimidate, ketamine. I'm sure you've heard of these. Propofol works by activating the GABA complex in our brain. So it keeps that GABA channel open and allows a large amount of chloride to cross the cell membrane. So what it's eventually going to do is prohibit or to prevent that pain receptor from firing. Etimidate works on the GABA receptor as well to depress our central nervous system. Ketamine is a non-competitive antagonist. It activates our opioid receptors in our brain. So what are the effects on our body? Well, propofol is going to decrease the brain's cerebral metabolic rate of oxygen consumption. So that's going to help to reduce our intracranial pressure. Propofol also has anticonvulsant properties. Etimidate decreases cerebral metabolic oxygen consumption, but has less effect than what propofol would have on our blood pressure and pulse. Ketamine has bronchodilator properties. It does not depress the respiratory drive as the other two do. It also has some pain relieving properties. These medications are used to induce general anesthesia, and sometimes we even use them for conscious sedation. It depends on what we're trying to do, client factors, depending on which one we're going to use. Contraindications would be if you already have a sensitivity to a sedative hypnotic. If you have an egg or soy allergy, we don't want you using propofol. Etimidate can depress our adrenal suppression, or can cause adrenal suppression, so we don't want to use it in someone who's chronically ill. And ketamine, we don't want to give to people younger than 3 years of age or those that have a history of schizophrenia. Side effects, most common side effects are going to be sedation, amnesia, respiratory depression, and they could have all the way to apnea. The most significant side effects with propofol administration is going to be hypotension. One of the major adverse effects when receiving etomidate is adrenal insufficiency, as I mentioned earlier. Ketamine can cause hallucinations and vivid dreams and may cause increased salivation, which can increase the risk for a laryngospasm. So one day I'll have to tell you about my experience with ketamine when I was in the ER. It does cause wild hallucinations and dreams. So we want to talk about these medications that they're taking, or the medication they're going to be given, what the purpose of it is, how we're going to give it. These are not medications that they're going to have in their home. They can only use these under supervision of a licensed healthcare provider. We will be monitoring them continuously while we have someone on this. We're going to be monitoring their respiratory rate, their blood pressure. We don't want them getting up and driving as soon as they finish taking this medication, because that's going to stay in their system for a while. Another medication that we have listed here is going to be our synthetic opioids. We're talking about fentanyl. It's a synthetic opioid, and this is not the street fentanyl, so you get people all the time, I don't want to take that fentanyl, it's what's on the street. This is a different one. This is an actual manufactured one, not one that was manufactured on the streets, okay? It acts on the mood receptors to relieve our pain, and it increases our anesthetic. When you go into the ICU, you may see some patients on fentanyl. It can contribute to hypoventilation. It can reduce their respiratory drive. It does cross the placenta, so we really don't want moms to be taking this while they're pregnant. Indications for use, again, for pain, it can block some of the sympathetic response when we've got someone who's intubated. It can suppress their airway reflexes, so that's going to prevent them from coughing and having a bronchospasm, like, for example, while we're doing a laryngoscopy. Contraindications, of course, is going to include hypersensitivity, and we want to use it in caution with people that are taking MAOIs. Side effects that we would expect: sedation, dry mouth, headache, respiratory depression. Now, they might even get a euphoria. Some people do kind of like that feeling as they're going under or coming out of the med. Adverse effects would be skeletal muscle rigidity, difficulty breathing. The higher the dose, the increased risk of difficulty breathing. Opioid-induced hyperalgesia, so a lot of pain numbing effects of it. They can have cardiovascular depression, hypotension, respiratory depression, and adrenal insufficiency. We don't want them driving for 24 hours after the procedure, because it can impair their decision making. The next medication we're going to talk about is succinylcholine. You may hear it just called Sux for short. It is a depolarizing agent. What it does is it's going to cause initial muscle contractions followed by paralysis. When I'm talking about paralysis, their whole body is paralyzed, so they cannot breathe. So we want to make sure we have some type of breathing tube right there. So again, it gives us the paralysis. When we have that, we have the risk for increased potassium release. So we have to watch these people that we give this to for hyperkalemia. Again, usually we only give it in surgery. Rapid sequence intubation is when we might use it. There's some other things that they're using now instead of that. So we want to make sure that they don't have hyperkalemia, any neuromuscular disorders. We also want to know they might have a risk of malignant hyperthermia. So we're going to ask the family if they've ever had problems, or ask the clients if they've ever had problems with anesthesia before. Let them know what's going to happen when they take this medication. Usually by the time we administer this, they are already out from some of the other medications that we've given. So on one of the prom shows that I watched, this is several years ago, there was a nurse that wanted to kill his wife. And so he stole some succinylcholine from the hospital and he gave it to her. He gave it by injection to her. Imagine her laying there and not being able to breathe, having that paralysis. So that's one way you can remember that. She lay there and she died because of she couldn't breathe, she couldn't move anything, she was totally paralyzed.